So, welcome to the first lecture on the Mulligan approach. Today's topic is Introduction and Application of Mobilization with Movement. I'm your physiotherapy student Chris, and let's get things started. The Mulligan approach refers to the approach developed by Mr. Brian Mulligan. It's a relatively new approach to manual therapy, with the corner piece being mobilization with movement. Mobilization with movement involves applying a sustained accessory glide to a joint while the patient performs a specific active movement. The aim is to achieve pain-free, functional range of motion. Mr. Brian Mulligan is a well-known figure in the field of physiotherapy and manual therapy. He is a New Zealand-born physio who has made significant contributions to the development and promotion of his approach of Mulligan concept. He's a student of Mr. Freddie Caldenborn. Over the years, Mulligan developed not only mobilization with movement for peripheral joints, but also snags and nags for the spine, as well as pain release phenomenon techniques. So let's discuss the principles of mobilization with movement. There are the acronyms of PEARL and CROCS respectively. So we'll talk about the CROCS first. So CROCS means that there's the contraindications. First for C. Manual induced forces applied to a patient by a physio ought to be considered in light of the state of the underlying tissues, as well as the underlying pathology, both locally and generally. Contraindications like hypermobility, joint diffusion and inflammation, or precautions include malignancy, bone disease, unhealed fracture, excessive pain, total joint replacements, newly formed or weakened connective tissue, systemic connective tissue diseases, etc. Repetitions. The number of repetitions per set and the number of sets per session vary between techniques, as well as the stages of the intervention. It is generally advisable that fewer repetitions should be used when treating the spine compared to with peripheral joints, particularly on the initial application and in more recently injured joints, or injuries with more severe pain presentation. More repetitions are used in more long-standing cases and as a progression when the patient's condition improves. Overpressure. All joints have an active and passive available range of motion, with slightly more passive than active range. In all mobilization with movements, the range of motion should be as a with range of motion as an endpoint criterion. Overpressure is applied. The maximum passive range is achieved by therapist applied firm overpressure at the end of the joint's range of motion, actively, as in pain limited range of motion, or it may be a maximal contraction in the cases of stiffness or weakness limited range of motion. If pain-free overpressure can be achieved at a symptomatic joint as a consequence of a MWM technique, then it is believed to ensure optimal recovery. Failure to test overpressure for pain responses may hinder the recovery of the specific joint being treated. C is for communication and cooperation. These are essential features of safe and effective MWM application. Practitioners must inform patients of expected effects, and patients must communicate with practitioners the presence of any symptoms discovered or pain during each treatment session. K is for knowledge. Practitioners must have knowledge of MSK medicine, pathology, biomechanics, and anatomy. This will enable the safe, efficient, and accurate application of techniques. Sustain. MWM techniques incorporate accessory glide with active movement. Ensure the glide is maintained during the entire duration of the movement, even upon return to the starting position. S can also stand for skill, sensibility, subtle, and common sense. Skill in manual handling of the physical application of the technique. Mobilization with movement is a skill like any form of manual therapy. The more the therapist perfects the skill, the better the technique will be performed. Sensibility, again, with practice, the therapist will gain greater sense and feeling through their hands. This will enable awareness of the joint gliding, physiological movement, and subtle changes in muscle tone associated with pain and guarding. Subtle changes in glide direction, which are often required when a technique does not achieve the desired aims. For example, a patient may feel the movement is improved by the application of mobilization with movement, but may still feel some pain with movement. Subtle changes in the direction of the glide may eliminate the pain completely. Finally, S also stands for common sense. Most of all, therapists ought to bring a reasoned approach to rationalizing indications, contraindications, communication, cooperation, knowledge and evidence, and skill in individualizing the mobilization with movement to the patient they are treating. The other acronym, PEARL, stands for pain-free, instant result, and long-lasting. Pain-free refers to both the mobilization and movement components. Instant result means that at the time of delivery, there is an immediately pain-free improvement in function, which is not true in many manual therapy techniques. Long-lasting means that all or most of the improvement gained is maintained. If the patient regresses between visits and there is no obvious correctable reason for this, after 3 visits you can say that the mobilization with movement are not indicated. So we'll talk next about the first success with mobilization with movement. So in 1984, Mulligan had his first MWM success, which completely changed his whole approach to manual therapy. The patient was someone he's been seeing for like some time, but cannot alter the status of the condition. The patient presented with a grossly swollen finger, which painfully with painfully limited flexion and extension following a sporting injury. The Mulligan used contemporary treatment techniques such as ultrasound and traction, as well as medial and lateral joint glide mobilization. Nothing appeared to significantly improve the patient's condition. Mulligan again attempted a medial glide technique, but the patient reported this as painful, and then he tried a lateral glide, which the patient did not state that it hurt. In a moment of inspired lateral thinking, Mulligan asked the patient to try to flex the injured finger while he sustained the pain-free lateral glide. The technique was immediately successful and restored the full range of pain-free movement to the joint in both flexion and extension. Further repetitions rendered the patient completely symptom-free after only one treatment session. A telephone call several days later revealed that the pain had not returned and the swelling had completely reduced following a single application of mobilization with movement. So we'll dive deeper into the mobilization with movement technique with the movement element, the second M of the mobilization with movement, MWM. So, the client-specific impairment measure, CSIM, is the movement element in mobilization with movement. It is critical to identify the task that the patient has difficulty completing, usually due to pain or joint stiffness. CSIM needs to reflect the patient's chief complaint, which in many ways is similar to the Maitland's comparable sign. The CSIM is a physical task or functional activity that the practitioner is able to evaluate, and that is comparable to the patient's presenting problem. The CSIM assessed in the clinic may be the task itself or a task that is reproducible in the clinic, but is not readily amendable to the application of a mobilization with movement. If the patient's functional demonstration is too painful to repeat it for the trial and error process of the mobilization with movement, it could be broken down into its constituent parts, like if it's a deep squat, which is too painful. You can try a knee flexion in non-weight-bearing position, which may be limited but less painful, and use this instead of the deep squat as a starting point. The CSIM's importance lies in connecting the treatment effect with the patient's problem, making it more meaningful for the patient. The CSIM is also help direct the therapist in deciding various treatment parameters. The endpoint of the client-specific impairment measure is a quantity, numeric pain rating scale for pain, range of motion for range, or force production. Let's say a pain-free grip strength in tennis elbow. After discussing the movement element, we'll talk then the mobilization element of mobilization with movement. There are two reference points for the parameters of the applied force vector, which is the mobilization element. One is in reference to the description of the input parameters, such as the amount and direction of force. The other reference point is the CSIM, and in particular how the parameters impact on the CSIM, which is ascertained through changes in output. The direction of force application is predicated on the best possible outcome of the CSIM at the time of application and initially afterwards within that treatment session. The direction of force application refers to the direction of the accessory or passive physiological motion that the practitioner is seeking to exert at the joint. For example, accessory motions may encompass medial, lateral, anterior, posterior translations, traction, and rotational joint forces. It is uncommon that flexion extension or abduct, ADD duct will be used as the mobilization force. Any of these passively applied forces will be sustained while the patient undergoes a CSIM. Apart from the recommended direction of force application for a particular mobilization with movement, the practitioner may also employ some other basic guidelines to select the initial mobilization to use when first applying a mobilization with movement technique, such as the concave-convex rule in the Caldon-Born approach, or simply opposing the direction of the mechanism of injury. In applying any joint glide, the practitioner should also be aware of the concept of the treatment plane, which is defined as the plane that lies perpendicular to the joint to a line drawn from the axis of rotation of the convex member of the to the center of the concave member of a joint. It is believed that to be effective, all MWMs will be either applied parallel or perpendicular to this treatment plane. For the direction of the force application, the therapist should not only consider the gross, but also the subtle. In order to seek a larger effect, the practitioner may wish to modify the glide direction to attain a better outcome, which may be achieved by fine-tuning the inclination, such as instead of a pure lateral glide, the therapist could try 10 degrees anterior inclined lateral glide or a 10 degrees posteriorly directed lateral glide to see if there comes with it increased efficacy. So how is the mobilization with movement different from other manual therapy techniques? So it combines mobilization with movement. Mobilization nor movement is new, so mobilization is in the Caldon-Born's approach, a passive glide, but it's now sustained throughout the active movement, and the active movement is in the Maitland's comparable sign, so it is meaningful to the patient. There is no other concept in the field of the manual therapy that is applicable to the entire MSK system, and that when indicated gives you an instant pain-free result. There is no other concept in the field of manual therapy that only requires 2 to 3 minutes to establish if it is indicated. A bonus is that when indicated, it is diagnostically significant. So these are the words of Mulligan himself. So for the last part of today, we'll talk about the efficacy of the mobilization with movement. So in the systematic reviews, identifying 38 papers, studied participants with a MSK condition who were treated with a mobilization with movement technique. So 6 were true randomized control trials, and further 9, while randomized, include a crossover feature of the 3 other trials. 16 reported single cases. So the majority of the randomized trials focused on initial and short-term effects. There's level 1B to 2A evidence that mobilization with movement is effective for tennis elbow management. The pooled data from a number of trials showed the immediate effects of mobilization with movement for tennis elbow on pain-free grip strength and pressure pain threshold to be superior to control or placebo groups. There's one high-quality randomized control trial that shows that mobilization with movement in combination with exercise is superior to control or superior to corticosteroid injections. Level 2A evidence suggests that mobilization with movement is superior to placebo and control in patients with subacute and recurrent ankle sprains. Pooling of immediate effects studies indicates that mobilization with movement at the ankle improves dorsiflexion beyond that of control comparators in patients with recurrent ankle sprains. Cervical mobilization with movement next has been shown to be effective in managing the cervicogenic headache symptoms in separate RCTs. Given the dearth of the high-quality studies, there's insufficient published evidence to support or refute the use of MWM in the shoulder, wrist, hand, spinal region, hip, knee, ankle. There's a further need for further RCTs of mobilization with movement and a need for longer-term follow-up of outcomes. So as a summary, so we've talked about how the mobilization with movement is in the Mulligan approach, is the cornerstone of the Mulligan approach. The Mulligan approach is developed by the giant and physio of Brian Mulligan, and we've talked about the principles of mobilization with movement. It's first success, the mobilization element of it, the movement element of it, as well as how it separates itself from other manual therapy techniques, as well as a brief discussion about the efficacy of mobilization with movement. So here comes the end of the first lecture. So I hope that you have enjoyed this and hopefully you get something out of this. Thank you. My name is Chris and I'm a physiotherapy student. See you next time.